Greetings. Thank you for joining us today. I would like to welcome you to a video. This is going to talk a little bit today about cognitive changes after brain injury, helping caregivers understand what cognitive changes can look like in their loved one after brain injury, and a little bit about what neuropsychology is for those individuals. I'd like to welcome our speaker, Dr. Derek Campbell, who's a practicing neuropsychologist here in Central Iowa. He's been in the field for 20 years and been practicing in private practice here in the Des Moines area for several years. So I'll let him go ahead and get started.
All right, well, first, thanks for the opportunity to present. I hope this proves useful. We could certainly spend an entire day or weekend talking about this incredibly important topic, but purpose of this video is just to provide a reasonable brief overview of common changes to make caregivers more aware of things to look for and how to cope. I hope it is beneficial. So a few objectives to start here. The first would be just to become generally aware of the cognitive functions that individuals suffering from really all severity levels of traumatic brain injury might demonstrate. And then additionally to go a step beyond and talk about how caregivers and patients experience those in terms of the impact on their daily life, their work functions, parenting, financial management. So the real world impact, as it were. Another goal, hopefully, is to provide at least some brief strategies once you recognize some difficulties in certain cognitive areas. Discuss some strategies to mitigate the impact of these and compensate to improve quality of life. And then finally, the goal would be to briefly discuss how assessment or neuropsychological assessment can be a valuable tool in promoting recovery and awareness of change after traumatic brain injury. And I should mention that I'll be using interchangeably the terms concussion and traumatic brain injury. So just to let you know, I'll be talking about the same thing when I use those words. Some basic considerations before we continue. I think most folks are aware, have seen the statistics on traumatic brain injury put out by Centers for Disease Control and Prevention. Millions of Americans affected by traumatic brain injury as patients every year. But certainly there's a lack of real understanding concerning just how broad the scope is in terms of caregivers. So it's a major problem. And as I mentioned in the earlier slide, one of the things we'll be talking about is cognitive problems really happen across all levels of brain trauma, ranging from mild concussion with maybe minimal loss of consciousness to very severe traumatic brain injuries associated with coma and protracted recovery. And I want to also highlight that the kinds of cognitive difficulties that are seen across recovery can happen at any time, early, middle, late, and they can ebb and flow based on other variables. As it's probably well understood by folks, these kinds of cognitive issues have a significant impact on a person's ability to work, their role in the family, how they interact with friends, and the community at large. And I think it's worth noting as well, and I think folks are probably, unfortunately, familiar with this issue, the misconception that can accompany brain injury. The term walking wounded comes to mind. Brain injuries are interesting in that often a person outwardly looks just fine physically, and as opposed to a broken bone or cancer, which can have obvious significant physical effects. A person with brain injury can look just fine on the outside, but suffering on the inside. And the problem with that is that if other individuals, whether it's healthcare providers, employers, family members, friends, if they're not recognizing some of the issues, it can cause excess disability associated with depression, tension, headache, lots of things. So I just thought it would be worthwhile highlighting that. So I've listed here some commonly impacted cognitive domains. This is certainly not an exhaustive list. I wanted to throw out the main areas that I see in the clinic and that I thought caregivers and patients would most identify with. There's certainly many, many more areas that we cover, but I just wanted to hit the highlights. So when I discuss attention and concentration, what does that really mean? Often people say, I can't pay attention. I just don't have the ability to concentrate. And in the neuropsychology world, we operationalize this as a person's ability to sustain mental focus enough to recognize that there's been some kind of environmental change and adjust to it. And additionally recognize that change in the environment or in their thinking is relevant to them. So in other words, just sustaining your focus sufficiently to know, okay, there's something I need to attend to. And some of the things you can find in individuals suffering from concussion or traumatic brain injuries are things like, I often hear folks say, it's interesting, once my husband or wife, once they're involved in a television show and somebody enters the room and they don't even acknowledge their presence, they don't seem to redirect their focus. Or they'll talk about in conversation, it seems like the patient is maybe not interested because they lose their train of thought as if they had other things that were more important, or they misinterpret what's been said because their mind wandered to a separate topic. And really this is related to just attentional capacity, not motivation. Another thing you often hear folks talk about is, on the phone, they'll begin the phone number and just can't even recite it immediately after. So really, attention concentration is a fairly brief mental process and basic in its nature. So some ways to cope with this, and there's no magic bullet here, as if with many things. You want to limit the distractions so that the person doesn't have a lot of things to attend to, and presenting information in manageable chunks, shorter sections or statements, that sort of thing, so that they can put them together in meaningful ways. And some of you might remember in your psychology classes when you're taught chunking meant linking things in a meaningful pattern to make them easier to remember. So numbers like 8, 3, 6, 5, 4, you want to chunk to 83654. So it's basically trying to make the information more manageable. Pause when you're talking with folks, especially during important discussions, and ask, okay, did you understand what point I'm trying to make? And you want to do that, of course, in a non-confrontational manner, but something that lets them know that you do care, that they're on the same page. You shouldn't assume that they've been able to sustain their focus throughout that conversation. And finally, another thing that's not always self-evident is that as you walk in the room, if there's something important that you need to talk about, don't assume that individuals with concussions, brain injuries, just know that implicitly. Try to say, okay, this, I need your full attention. Let's turn off the television and the radio, and I need you to focus on this because it's important to our lives. Short-term memory difficulty is maybe the number one complaint in individuals with traumatic brain injury. You hear things like, my short-term memory is poor, I have forgetfulness, but my long-term memory is just fine. Of course, long-term memory refers to events taking place many years ago. And really from, again, an operational standpoint, the memory refers to, you learn something and then recalling it or recognizing it a number of minutes later, around 20 to 30 minutes, basically. And you can have this affecting verbal memory, conversations, reading material, nonverbal or visual, routes while driving, faces, graphs. And the thing to note about the nonverbal or visual is that often we can use verbal memory to work around visual memory deficits by verbalizing certain things like, okay, while I'm driving, I remember I need to turn right on Main Street and then left on 3rd. So there's a lot of blend between verbal and nonverbal memory. And some examples that you'll probably see in your loved ones is, they seem to be paying good attention, but they're pretty patchy in their recall of details of conversations. They might get the gist of it, but fairly inconsistent in terms of importance. Or they repeat themselves without recollection that we've already had that discussion. When I say misrepresent information, you can have an interesting phenomenon where they might have some good details of past discussions, but the context is lacking. So the who said what and where and when might be inaccurate. So you can't rely on individuals with concussions to always know how they came upon that information. Getting lost while driving, even if it's a familiar route, misplacing personal items or other things that you can certainly experience with this kind of short-term memory loss. Some ways to cope, and in the technology age, there's a lot of powerful tools out there, smartphones with reminders, iPads with calendars and alarm systems, etc. Are extremely powerful, and they're making them easier and easier to use, even for generations that perhaps are not overly familiar with technology. If you prefer more of the traditional method, those daily calendar notebooks are very helpful, especially if they're small enough that it can be carried with patients. Sometimes you can get into some trouble if it's a daily calendar notebook that's so large they don't carry it with them, and then little notes they take about upcoming schedule where they need reminders like appointments just never make it to their notebook left at home. So you have to be careful about that. Reminder lists are helpful. Also, prior to a brain injury, you might listen to a conversation, get the main points, and never need to return to it again. But with individuals with some brain trauma, need to go over that information every so often to make sure that it's been retained. And then the last two, alarms on the watch. That could be just alarm goes off on the watch to make sure that you check your daily calendar notebook, because if you're using the written form, you may not have the reminder to go and check. That's one of the benefits of those digital tools, because they actually will give you an alarm built in. And last thing, place for everything and everything in its place. Basically, easier said than done, but trying to get the household and work environment very organized so that if you're prone to misplacing things, you just automatically, without thinking, just have a tendency to put certain important items in the same location. Keys, purse, wallet, your calendar, checkbook. Try to keep everything where you don't even have to think about where the last place you put it was. So. Language difficulty, also very common clinically. Folks will come for a neuropsych assessment, often say, I can't describe it. I feel dumb because I know what I want to say, but I just can't seem to get it out there. Or they can't keep pace because there's some damage in the language center of the brain where it just takes them longer to process, or they have some distortion. So they seem to miss out on some things in discussions, or naming difficulty. They'll uh, cannot think of common tools, or the names of certain types of animals. And they've known this for all their lives, but just doesn't come. It's very frustrating for patients. And you'll see this, as I referenced already. They pause a bit to find their words. They use wrong words, or they just skip because of frustration. No easy way to really cope with this in terms of strengthening linguistic processing circuitry. You kind of have to work around it and be patient. Um, any of the really good rehabilitation professionals will tell you, as a caregiver, try to allow the person plenty of time, as long as their level of distress is not rising. Give them time to come up with the words, and they usually will. And if you allow that, it'll build some mastery and self-confidence. Slow down when you're having discussions, and also encourage your loved one, the patient, to slow down and be more deliberate in their delivery of information. That allows the brain to catch up with the thoughts, as it were. And then encourage your loved one to plan ahead for school presentations, work meetings, etc. There's no great substitute for being prepared. So, if you're worried that you might stumble over your words in a presentation, then it's unfortunate that you have to do this now after a brain injury, but now you're going to have to prepare doubly, perhaps. But it will make a big difference in terms of errors and fluency. So, slower information processing speed just refers to how quickly the brain recognizes, organizes, and manipulates information presented either verbally or visually. And individuals will complain, well, I'm talking and it just takes them, my loved one, quite a bit longer to respond. I don't know if they're in there, or they have trouble if you're speaking probably at a rate that I'm speaking, a little too fast. They don't keep pace and need you to repeat yourself. You have to watch driving when processing speed is slowed, because, of course, the driving environment changes very rapidly, and you need to recognize and adjust to that quickly. And that can sometimes be tricky for individuals suffering brain trauma. And if it's not even on a basic level, just doing projects around the house, fix-it projects, laundry, cooking takes longer. And you just have to be patient. And reading speed, again, is pretty self-explanatory. Things to manage, and some of this I know will seem like common sense, slowing down. Fatigue, and this happens for all of us. As we get more tired as the day progresses, I think everybody experiences a little bit of sluggishness mentally and slower, but this impact will be amplified in brain injured populations. So be aware, and maybe adjust accordingly in terms of having important meetings or other activities occurring when the person is at their best physically. Electronic aids are really helpful for students, for example. Attending the lecture can be pretty tough because, as they're trying to take notes and they can't keep pace, the instructor has already moved on. And tape recording those then, of course, allows you to stop and review and move on. So when I mentioned delegating, given that a person suffering brain trauma takes longer to do things, if there are some non-essential tasks that can be given to somebody else, like for example, the work environment, if a manager, and just out of habit, does certain scheduling that could easily be given to a supervisee to free that person up to perform more essential tasks, do that. Don't be too proud. And you could do that at home as well, with things like managing the checkbook or other parts of the routine. So a lot of things can be done here. Working memory can be a confusing construct because we know about short-term and long-term memory and attention. Well, what does working memory mean? It's more of a brief holding area for information, allowing a person enough time to figure out how to act on the material, um, understand the relevance, so manipulate the data basically. It's longer than attention. Attention is very short. Repeat these numbers, 1, 5, 8. Or working memory requires you to listen to perhaps a discussion point of paragraph length, like, oh, tomorrow we're going to go to the store at 8, and before we go, we've got to pick up this and that from the hardware store, etc. And then you miss out on those details because you just were not able to hold the information in mind to understand the sequence. Yeah, so you'll hear people say, you know, I can see they're looking at me, they're attending to what I'm saying, but then at the end of the conversation, they really missed out, and that could relate to a working memory deficit. Or the person asks for repeats of longer conversation, like key details or figures, like, okay, what did you say in terms of how much we're going to pay per month on that particular bill? And what is the deadline for that? They may get the gist, but again, miss out on some important features there. So, and ways to try to work around that. Again, no magic bullet, nothing, you know, no rocket science here, but taking notes. A little trick that I often recommend to folks in the working world or even at home and in parenting, dealing with the school system, is if you can request that folks not just, you know, don't call, talk to me a little bit, and then assume that, you know, I will actually have understood the information. You know, if you could drop me an email so that I can review it later, or you know, leave a voicemail so that you know, I don't miss any details. Most folks involved in caregiving and working with brain trauma are very, very open to this because it covers both sides. They know that the information has been conveyed and accurately, and that will be acted on appropriately. And then finally, for this topic, you know, cover, or this area of cognition, cover one topic at a time so that you don't end up mixing different points, because working memory, if you're having trouble keeping things in mind long enough, you might accidentally insert some wrong times or figures in an unrelated area of the discussion. So try to keep it simple. Prospective memory is remembering to do something at a later time. Another common complaint, it's like, you know, we talk about going and doing this after work and the person doesn't show up, or they are at a doctor's office and talk about setting an appointment up for next week, and they're going to put it in their calendar later, but it just never makes it there because after they leave the office, they forget to do it before they you know, go to bed for the evening. So it's really remembering to do something at a specific time. And the way to get around that, again, nothing really complicated here. It's better to assume that you will not remember and make adjustments accordingly. If you can do it now, whether it's scheduling something or making a phone call, do it right now. Then you don't have to worry about it. Set reminders, delegate to others. You know, say, look, you're attending that meeting tomorrow, and would you mind stopping by my office, you know, so we can prep before, and give me a call before you're heading over, so that you know, I make sure that I'm there. And set aside more time than you used to. Recommend your loved one, you know, take a look at that calendar about the week or daily activities. Try to do it in the morning. Make sure you also do it a couple times during the day to make sure you're up to date. Just get in that habit so that you won't be surprised if you've missed out on something. So be proactive. Reasoning, a fairly nebulous concept. You know, some of the common things folks will say is, you know, they just don't seem to put two and two together. They don't understand that, you know, we've we've had this budget forever, and now they're wanting to change it. They go to meetings and don't seem to get the big picture. So it's a higher level skill. It's hard to teach a person with reasoning difficulty a way around it, because it's like having a very faulty engine. You have to actually figure out another way to get around for a while, and that's where the strategies of trying to use others like spouses to say, please don't make decisions on your own. I know it stinks, and that's where I say, while respecting autonomy, with parenting or with budgeting or work things, like, let's not assume that a person who might have spearheaded those decisions, let's not assume anymore for a while that they're always going to make the right choice. So let's, run it by me phenomenon. Let's just, get together and review and make sure we're on the same page. Sometimes it helps to make explicit certain goals. What are the issues we need to discuss? If there's some gaps in logic that you notice, like, well, you're saying that we're going to be able to meet with this person on this date, but you remember, we won't have all of the information in prior to that meeting for long enough to review. So let's move it back. Again, things that used to come easily to folks with traumatic brain injury after can be quite daunting. So executive functions, the big whopper, very broad concept. And as the name itself would connote, like an executive of a company, this is the allocation and integration of resources such as attention and memory and planning. How do you organize and evaluate whether your strategy was actually effective? And I mentioned that it's a difference between word and deed. It's a very fascinating phenomenon that individuals who present for neuropsych assessments can actually talk about a lot of different scenarios, family conflict, work resolution. They can talk about the right thing to do, but then in the moment, when you add emotions in there and you add some other limitations like stress, pressure, even though they, in the abstract, know the right thing to do, it just doesn't always happen. And it's quite a puzzling phenomenon. And again, this one's difficult to make go away, but you try to, again, work around it by simplifying things, helping the person plan. When I mentioned decision-making processes, again, sit down, identify goals, identify how you will concretely determine if those goals have been reached, what things were successful, what things did not work, and review this kind of process more than you used to. Whether it's as a couple, how you're managing your children's schedules or conflicts they may be having with students or at work, personnel decisions. Try to review and determine, are we handling things the way we need to. One of the final points I wanted to make is that even though this talk was not aimed at talking about areas aside from cognition, you really have to look at the whole person and how they are suffering after a brain trauma, chronic pain, headache, musculoskeletal pain. Anybody who's ever had that, even on a short-term basis, knows that interferes with ability to concentrate or think clearly. So that plays a role. Mood dysregulation. We could spend another day basically talking about depression and anxiety disorders following brain trauma and how they impact functioning. Lower self-esteem, that sort of thing, will affect a lot of different cognitive processes, including reasoning, because if you don't feel like you have the wherewithal, you may withdraw a bit from that and complicate matters. And then there's just the practical side of this, loss of income because you're not working, or heaven forbid, you can't drive anymore for a while. insurance, legal processes. These things tend to add stress and sour mood in my experience, and really need to be addressed in the assessment and management process. And of course, and I know the last one is very obvious, especially to the viewers, but it's a major area of positive impact is good support from friends and family and coworkers and community at large. The more you have that, the more, again, you develop a sense of mastery and belonging, which can go a long way to facilitate recovery. And now that we've talked about some basic areas that are affected by a concussion, one tool, and I'm biased, I think it's a very useful tool. It's the line of work I'm in, the Neuropsychological Assessment. A lot of folks have never heard of this, but it's been around for many years. And it's a nice way to operationalize a lot of different aspects of functioning, cognition, emotions, how the person's behaving, find out, okay, what exactly is going on by giving a standardized assessment, looking at things like memory and concentration, language, and reasoning, try to figure out, compared to population norms, for example, how are you performing compared to somebody in your same age range with a similar educational background? Are you in the average range, or are you well below that? And if so, what's the practical impact? Can be very powerful, especially in tracking recovery for folks. And some of the assessment tools I don't need to go over in detail. I know I'm pushing time here, but the interview usually lasts a good hour and a half, going over what are your complaints, how are you struggling in terms of the practical impact, a review of history, medical, neurologic, substance use, family life, education, occupation, mood assessment, talk with informants, caregivers to provide who can provide a really good account of functioning. And then we roll into the actual testing portion to determine in a quantitative way how they've been impacted. Considerations would be that I usually look at is I want to make sure I understand why the person's been referred. How can I help the referring physician? What do they want to know? But maybe, and probably more importantly, what does the patient and family want to learn from the exam? You can really foster a lot of cooperation and engagement if you ask, how can I be of use to you? It's always nice to try to figure out where a person came from in terms of premorbid abilities and intellectual functioning, et cetera. And you can do that with a variety of measures and aspects of the interview in terms of educational attainment and current occupation. I always try to provide feedback about results face-to-face. Here are the areas that you look good in, and here are some areas of weakness. Do I expect recovery? Here are some ways that they will impact your life, coping strategies, and then try to answer any questions that patients and family members might have. So we want to just say thanks to everyone viewing and the Brain Injury Alliance for giving me this great opportunity. Hope you have a good rest of the day.
Thank you so much to Dr. Campbell, and we'll just piggyback on that. Thanks so much to the viewers, and you can always give us a call if you have any questions. Thank you.